and a company called Imogen, which does some imaging, artificial intelligence stuff. And I will be talking about OrthAlign in here in this talk. So when we talk about a simple accelerometer-based navigation system, through its development, there were some very strict ground rules, and they were ground rules to make sure that it was something that surgeons would want to use. So if we look at those ground rules, first of all, no large console navigation system that needed to be in the room, no large capital equipment investment. Hospitals just don't want to spend money on this stuff. Everything needed to be part of the surgical field. So we wanted everything right in front of us, sterile in the surgical field, so we didn't have to look outside the field or touch anything outside the field or have somebody non-sterile address anything outside of the field. No line of sight issues. Anybody that's used robotics or large console navigation systems know the issues with line of sight issues and either not being able to see the arrays or assistants having to duck out of the way while holding retractors in order to be able to see things. And just as important as all of the rest was keep it simple, make it something that surgeons would actually want to use. And if we think about what we're doing with navigation in hip replacement, for the large majority of hip replacements, the acetabular component position is important, but it's not important to be accurate within 1 degree. We need that acetabular component to be close. We don't want to see an x-ray post-operatively that surprises us. And leg length is critical. No patient comes into the office and says, hey doc, my acetabular component's at 46 degrees of inclination, and I read somewhere that it was supposed to be at 43 degrees. But they do come in and they say that my leg feels long, and that's something that they continue to complain about. And really, we don't want post-operative surprises, and we don't want the need for intraoperative imaging. Over the last several years, there's been a big push towards intraoperative imaging, especially with an increasing use of direct anterior approach. And we tried to do something that would take intraoperative imaging out of the operating room. So I'm going to go through a bunch of images. And these images are really to show you how simple the procedure is. It can be done either in the lateral position or the supine position. I think today, any technology, it's important that you can use in both of these positions for hip replacement. Patients set up the way that they're normally set up. I do a posterior lateral approach. This patient is set up lateral on the table. This is how we prep and drape. If you look close, there's actually a plate it's just an ioband that's holding this on the leg here. You'll see why we have that in a second. And then I've drawn out my incision just off the back corner of the greater trochanter. So 2 pins go into the iliac crest. So 2 vertical pins go into the iliac crest to hold the device in place. There's a clamp that goes onto those 2 pins. And then the accelerometer-based system is here. There's one part that has a battery in it that is non-disposable and one part that's disposable. And then there's a laser that actually aims at a target on the leg. And that's just so you can put the leg back in the same position every time you measure for leg length and offset. So the first thing you do is you have to register the pelvis. And as Steve said, and I'll grant him this absolutely, this depends on your pelvis being level when you start the case. So I always check on the position of the pelvis before we prep and drape. This isn't something that I let an intern or a resident or a first-year resident, second-year resident position the patient. I always check on the patient. You'll notice that we do the registration of the pelvis before we make an incision, before we do exposure, where you're going to have retractors in, people pushing and pulling the legs to change the position of the leg. And you can see I'm holding this bar, this arm, along the plane of the body. So this is adjusting for pelvic tilt. So when we look at it, so this is really giving us functional anteversion or functional position of the pelvis. So after that, we do our standard exposure. And then after your exposure, we mark a spot on this little plate here, which is just the spot that the laser points at. And the reason for that, again, is so that you can put the leg back in that position every time you check leg length or offset. And then there's a little tack, a little checkpoint that goes in the greater trochanter. It's a single checkpoint that goes in the greater trochanter. You put the probe into that point. You push a button on the device here, and it registers the initial leg length and offset. Then the device comes off. You keep the clamp that's just still on those pins. The device comes off, and you go ahead and you prepare your acetabulum the same way as you would normally prepare your acetabulum. So it's very comfortable to surgeons that haven't used any sort of navigation before, because you're reaming the acetabulum as you normally would. You then start to put your acetabular component in. So there's an acetabular insertion handle here. There are threads for every brand of acetabulum. So this is implant agnostic. You can use whatever implant you want. And I start by putting my implant partway in, so just a couple of taps, just so it gets a little snug in the acetabulum. And at this point, I'm looking at my bony landmarks, transverse acetabular ligament, putting that acetabular component where I think that acetabular component needs to go. And the way I teach the residents and fellows this is really what you're doing is you're putting that acetabular component in to get a good solid bite in the acetabulum, tucked under that anterior wall so you don't get iliopsoas impingement in the position that you think the acetabulum needs to be in. And then the device is to check. The device is to make sure that you don't mess up the position that you're putting the implant in. So the device goes back on the clamp. You push a button that's basically saying, hey, are you set up to measure the acetabulum? And then you move this battery-powered part from the device here onto the acetabular insertion handle when it gives you the green light to do that. And then it gives you real-time acetabular component position. So it gives you inclination and anteversion, both in the functional pelvic plane. So you can see in this case, this acetabular component is at 38 degrees of abduction and 25 degrees of anteversion. Okay, and then I think it's always important, again, we're surgeons, you can't just depend on this technology. You need to be able to look at what you're doing. So look at that acetabular component position, again, making sure that the anterior metal part of the acetabular component is tucked under that anterior wall. You're typically going to see a little exposed acetabulum, superior and posterior. You can use your transverse acetabular ligament for guide as well. So you're putting that component in where you think it fits in that patient's pelvis, and then you're checking with the device to make sure that there are going to be no surprises. So then we move on to the femur, and this is just standard femoral exposure for a posterior approach. I use a ream approach system. So this is me reaming here. This is a trial broach in place. And you can see we're about to do a trial reduction here. And then once you do that trial reduction, you reposition the leg. So the laser that's on here, again, you position the leg so that it's pointing at that point that crosshair that you've marked on this plate down here. You put the probe back in that checkpoint. You push a button on the device, and it tells you where you are compared to where you started. All right, so it tells us in this case, we've lengthened the leg by 3 millimeters and we've increased the overall offset by 2 millimeters. And then you look at your preoperative plan and decide how much did you want to lengthen the leg? Do you need to adjust it? Is this appropriate for this patient? So simple to get leg length and offset. So we've got some data for both posterior approach and anterior approach. The posterior approach is HSS data. So myself and a number of other surgeons using the device at HSS. This study was just over 300 patients. The inclination average angle was 41.6 degrees, and postoperative radiographs measured at 42.9. Again, those are averages. The standard deviation is a little greater than that. The standard deviation was about 3.5 degrees. So it's not a device that you expect to be within 1 degree. And anteversion angles were 22 degrees on the device versus an average of 23.6 degrees measured. Again, standard deviation is about 3.5 degrees. 77% of cases were within 1 millimeter for target leg length, and standard deviation was just under 2 millimeters. So really quite good or excellent in terms of leg length, and very good in terms of acetabular component position. If we look at anterior approach, and this is just an image of anterior approach and how you use the device for an anterior approach. Here we saw inclination angles 39 degrees with a standard deviation of 4.6 degrees. Now, these non-navigated numbers were with fluoroscopy. So really what this shows is that this device, a handheld accelerometer-based device, without any fluoroscopy for anterior approach was equal to a non-navigated with fluoroscopy, both for anteversion and for inclination. And leg lengths were within 1 millimeter of expected in 57% of patients and within 2 millimeters of expected in 79% of patients. So I think really quite good results, both anterior and posterior approach. Thanks very much.
Dave, that was great.